Thank you, everyone. Good afternoon. My name is Yemi Ilesanmi. I'm one of the endocrine registrars. I'll be presenting this paper titled The Efficacy of GLP-1 and Estrogen Dual Agonist in Pancreatic Islets Protection and Preclinical Models of Insulin-Deficient Diabetes. So, as we all rightly know, we are in the era of the twin incretins, and one example is tirzepatide, which is a GLP-1 and GIP dual agonist. And we've all seen studies showing superiority in comparison to semaglutide, which is a GLP-1 agonist. And you can see here on the left, greater decrease in HbA1c with tirzepatide, both at 5, 10, and 15 milligrams, and also a greater change in body weight compared to semaglutide, 1 milligram. So in this study, the authors, who are based in America, have come up with a GLP-1 and estrogen, or estradiol, dual agonist. And they've basically conjugated a GLP-1 that's resistant to DPP-4 inhibitor, so it won't break down in the circulation. And they've got a peptide linking it to estradiol. Apparently, I didn't know this, but you don't have GLP-1 receptor in the uterus or breast, so you don't get any estrogenic effects in these two organs. So why estradiol? Well, in rodent models, estrogenic compounds have been shown to protect beta cell survival and function in the face of multiple diabetic insults. And we all know that decline in beta cell mass is a major issue in patients with type 1 diabetes and type 2 diabetes. So in randomized control studies in humans, I'm just going to quote the heart and estrogen replacement study, but there's also the Million Women study, where they recruited 2,029 women who had coronary artery disease but no diabetes at baseline, and they gave them conjugated estrogen plus progesterone, and followed them up for 4 years. And they showed that 6.2% of women who received treatment with estrogen and progesterone developed diabetes, compared to 9.5% in those who had placebo. So then they recommended that for every 30 women treated for 4 years, they might prevent 1 case of diabetes. So in this study, the authors answer a few questions. And the first is, does the GLP-1 estrogen dual agonist provide additional benefits in protecting islet survival at the onset of insulin-deficient diabetes in animal models? And they've used 2 separate animal models. So the first model, they have a male wild-type mice, which is non-obese and non-diabetic. And they've given multiple injections with streptozotocin. Now, streptozotocin induces immune-mediated beta cell destruction. So you get macrophages, T cells, and NK lymphocytes, which attack the beta cells. They then infuse agonists of placebo, estrogen, GLP-1, GLP-1 bound to estrogen, and an inactivated GLP-1 for a duration of 12 days. So they start the agonist before they give the streptozotocin injection. And in each group, they have 10 mice. And in terms of the doses of the GLP-1 estrogen dual agonist they use, so they've used 120 micrograms per kilogram per day, which is quite a lot in terms of GLP-1 dose. So in humans, for example, exenatide, we give 10 micrograms twice a day. So this is super physiological doses in comparison to the doses we'll use in man. So at the end of, so each day they then do a random postprandial blood glucose on the mice, and they've plotted the mean and SEM of the glucose readings. And as you can see, so in comparison to placebo, estrogen on its own, GLP-1, you can see that the GLP-1 and estrogen dual agonist, in that group, you have a lower random blood glucose.
ask about that first point? Just go back to that for a second.
Yes.
See, that first point, before the strep was given, the glucose is a little bit lower than all the other groups in the purple one.
It's a little bit, but there's no real significant difference.
I know, but you know, when you're insulin resistant, those small differences might be, they're not significant, but it might be more, just a little hole in the algorithm.
Yeah, but also to say that the mice are still diabetic. So when I convert 200 milligrams into millimoles, it still works about 11.1.
Yeah, but at that level of about 150, it's very, I worry about it anyway.
Why is that group lower?
It's just randomly a bit lower, and it's not significant, but you can't use standard significance tests for that kind of difference. You can see it looks different. I accept the error bars might be wide.
So they've also, and the next slide, so they've looked at beta cell function, and the surrogate marker they've used for this is insulin divided by glucose on day 13, okay? So somewhere around there, once the infusion has finished. So the infusion finishes on day 12, and then day 13, they've done paired insulin and glucose. And you can see a placebo in black, estrogen in gray with quite good effects in comparison to placebo, GLP-1 agonist, a GLP-1 and estrogen dual agonist, and an inactivated GLP-1, which is a control. But actually, there's no difference between the GLP-1 estrogen and an inactivated GLP-1 bound to estrogen. So I can't explain that. But also, they've then shown just random blood glucose values on day 13. And you can see that there is a difference between the GLP-1 agonist and the dual agonist. So the dual agonist has the lowest random blood glucose on day 13. And just to show that there is no significant weight difference in these mice, so these are the 10 mice that had placebo, estrogen, GLP-1 agonist, the dual agonist, and the inactivated. I must say that there is a tiny bit of a weight loss, but it's not significant in the mice. So some of the differences that we can see in the insulin and the glucose might be attributed to weight loss, but actually there's no significant difference in the weight of the mice at the start of the experiment and 13 days after. Okay, so they then look at the effect of this dual agonist on reproductive hormones in mice. So just going back to the fact that these were male mice that they used in their experiment, and just to stress that the estradiol had no effect on gonadotrophins. They measured their LH, testosterone, and estradiol, and there is no significant difference. Okay, they also weighed the prostate, and actually it looks like they've got a few outliers with the mice that were on the dual agonist, but overall there's no significant difference in the weight of the prostate. I haven't presented the data for blood pressure and heart rate, but again, no effect on blood pressure and heart rate. So the second mouse model they use is called the Akita mice, which is a mutant mice that has defective pro-insulin, which then is misfolded, and as a result triggers endoplasmic reticular cells stress, which then causes beta cell failure. So they have this mice, and again, they do exactly the same experiment, but monitor the blood glucose for a little bit longer. And going back to Prof. Miran's point, the fasting, the glucose on day 0 is pretty similar across the 3 groups. However, there is a significant difference at lower glucose in the GLP-1 and the GLP-1 dual agonist. And although the authors report a difference in the glucose levels, the random glucose between the group on the monoagonist, so GLP-1 versus dual agonist, actually, when you look at the AUC glucose, there's no significant difference. And I think much of the difference that they can see here is just post day 15, but there's no difference in the AUC of the glucose. So they then do an intraperitoneal GTT on day 27 on all these mice, the Akita mice. And as expected, the fasting glucose is much lower in the mice that had GLP-1 and significantly lower in the mice that had GLP-1 and estradiol dual agonist. And looking at the AUC of the OGTT or the GTT, there is a significant difference between GLP-1 and GLP-1 dual agonists. So I guess this suggests that there is some improvement in a GLP-1 and estradiol dual agonist in terms of beta cell sensitivity and the ability to control blood glucose. So just to highlight that GLP-1 estradiol dual agonist activity is mediated by the GLP-1 receptor. They gave some of these mice exendin 939, which is a GLP-1 receptor antagonist. And as you can see in blue, this is the dual agonist, so random blood glucose all the way from day 43 to 64. And then in the group that had GLP-1 dual agonist plus exendin, you can see that they've got higher glucose. And then of course, placebo and exendin 939 itself, which causes diabetes because you block the GLP-1 receptor. So they were able to show that this dual agonist activity is mediated by the GLP-1 receptor. They then went on to show that it's also mediated by the estrogen receptor. And in this, they had female mice, normal weight, non-diabetic, and they had a wild type mice. And you can see in the estrogen receptor knockout mice, there is no effect of the dual agonist on glucose level. Yeah. So they remain hypoglycemic throughout, whereas in the wild type mice that have estrogen receptor intact, there is lower blood glucose. And you can see the AUC there. So their next experiment, which they ran in parallel, was to look at markers of apoptosis. So using caspase, which are basically a family of enzymes that are crucial for initiating and executing apoptosis within a cell. And so what they did was they cultured mouse islets and treated them with either agonist, estrogen, GLP-1 agonist on its own, and this dual agonist for 24 hours, and then exposed them to hydrogen peroxide for at least 5 hours. So they measured caspase activity on the y-axis, and you can see with just placebo, you've got low caspase activity. And then when you add in hydrogen peroxide, so these are all placebo plus hydrogen peroxide, you get increased caspase activity, showing that there's increased apoptosis in the islets. And then with estradiol, you get lower caspase 3 activity, but actually there is no difference between estradiol, GLP-1, and the dual agonist. Can everybody see that? Yeah. So the main difference is between placebo and either GLP-1, placebo, and estradiol. But actually, if you compare the 3 agonists, there's no difference in the markers of apoptosis. So although in vivo, they were able to show that these mice were less hypoglycemic, they haven't demonstrated that this is all secondary to reduced apoptosis.
Okay, they're all the same, all 3.
Yeah, exactly.
Okay.
All 3 the same. But compared to placebo, of course, they're lower. So I think that basically it's not just down to islet cell, I think that there are other mechanisms that are reducing the hypoglycemic effect of the GLP-1 dual agonist. So, you've got the brain, you've got alpha cell, which again, you wouldn't get if you've just cultured, if you've just taken the cells out of the mice. So through a series of other experiments, they then summarize the mechanism of the action of this dual agonist on beta cells. And I'll just talk you through it. So the GLP-1 estradiol dual agonist binds on the GLP-1 receptor, and through clarithin-dependent mechanism, it gets internalized into the cells. It then goes into the endosomes and gets cleaved in lysosomes, and then estradiol binds to its receptor in the cell. So the next question that the group wanted to answer was to look at this dual agonist versus monoagonist in human islets. And I'm really sorry, I think this projects really bad.
It's quite clear.
Yeah, okay, all right. So they had 3 human islets, and they didn't specify whether these were diabetic islets, and they just said human donor islets. And they cultured them with GLP-1, estradiol, or this dual agonist. And they basically looked at phosphoproteomics to look at the pathways that are activated in disease state. And they've given them a Z score. So a Z score greater than 2 in red were related to cell viability and survival, whereas pathways predicting inhibition were related to cell death and apoptosis and necrosis, and they had a Z score of less than 2. So greater than 2 is red, less than 2 in blue. And they basically looked at this phosphoproteomics at 5 minutes, 30 minutes, and 18 hours. So if I start on the left, you've got GLP-1 there, estradiol, and the dual agonist. And so you can see in the control on the left column, it's mostly blue, and blue is basically cell death, necrosis, apoptosis. I'm struggling to even see my own screen. But with estradiol, you can see that you've got more reds, basically, which is cell viability and survival. And GLP-1 dual agonist, again, it's a mixture of both. Okay, so here they've basically concluded that the dual agonist sort of activates pathways that reflect a mixture of both GLP-1 activity and estradiol activity. So basically, in conclusion, the GLP-1 estradiol dual agonist improved fasting and fed glucose and insulin tolerance in wild-type mice to an extent that's superior to the GLP-1 monoagonist. However, they weren't able to demonstrate any additional protection of the mouse islets from oxidative stress when they looked at the caspase-3 in comparison to a GLP-1 agonist or just estrogen on its own. They've also shown that in human islets, the GLP-1 dual agonist basically activates pathways that are a combination of both the GLP-1 agonist and estradiol. So I guess that in terms of the clinical relevance, I think that in patients who, say, are undergoing islet transplant and are obese, if this is translatable to clinical practice, this might be a treatment for those patients in order to preserve beta cell mass, or again in type 2 diabetes and obesity, where we know that obesity is a pro-inflammatory state, and we might be able to preserve beta cell function from the sort of inflammatory inflammatory destruction. So that's the conclusion of this very complex animal study.
Do you believe it?
Do I believe it?
Would you buy shares in this company?
No. I think they definitely need more data, and they haven't been, basically all they've been able to demonstrate is that this is probably pretty much mostly due to GLP-1 activity. I think estradiol on its own, yes, does improve glucose tolerance, but at the expense of all the other side effects that come with it.
And a small number of, it was 6% to 9%.
Sorry?
In the human study you mentioned, it was 6% to 9%. Yeah?
Yeah, 6% versus 9%. I mean, I haven't quoted the million women study, but I think they've also found the same pattern. But again, these women didn't just have estrogen, they had progesterone as well, and it was medroxyprogesterone, which isn't particularly physiological.
Any other thoughts from anybody else on this? I wonder if this will go anywhere.
Sorry?
Here we go. Ruth's got a hand up. She's an expert.
No, I'm not. I think this just highlights what they found with all incretin studies. When they do them in vitro and when they do them in mice models, they get certain results. And then until you do it in humans, then you might get a clearer picture. But then again, they're going to do clamp studies with smaller numbers of patients. So I think it's too early to really translate this into a clinical context yet. I think if they want to go on and study this, but you need the human studies, because the mice models often give very conflicting results. With GIP studies, that's what happened, and that's why GIP was also never developed further. So that would be my only comment. And I think it does seem to be a predominant GLP-1 effect, as you say.
Yeah.
Did the mice, was there any difference in, did they look at fat or did they look at weight in these mice?
They looked at weight, so I've presented their weight data here, but they didn't comment on fat, no.
Okay.
But yeah, they looked at the weight, and they haven't reported a significant difference, but you can see there's a tendency for the mice on the GLP-1 to drop their weight after 13 days. So that's a GLP-1 mice, and that's a dual agonist.
But it's quite a wide
it is
standard error there. So
it's a wide error bar, which means that one very sick animal.
Yeah, exactly. Yes. So I don't think you can make any firm conclusions from that.
Yeah. I mean, I think one of the questions I had was kind of the CNS effects and whether there would be protective, I don't know, sort of effects of the GLP-1 estradiol dual agonist.
We might find some quite unpleasant side effects.
Or do you think maybe the other way with the estradiol effects?
I don't know, but I mean, would you give it to a man?
Sorry?
Would it be okay to give males this drug?
Would it be okay?
Yeah, to give males this drug.
Not yet, no. They're far from it.
They get gynecomastia.
Well, they say that, you know, it's not absorbed peripherally because, again, you haven't got GLP-1 receptors in the breast, and there's no effect on like estradiol levels or testosterone levels.
Oh, I see. So the estradiol part itself is only liberated inside the cell.
Exactly. So if I go back to that,
okay.
So it's bound and it only gets cleaved in the lysosomes.
Actually, yes.
And the fact that you haven't got GLP-1 receptors in the breast or in the uterus is protective. And also this conjugate is resistant to being broken down by DPP-4 inhibitor, by DPP-4 in the circulation.
Okay.